very much, Sabine and Mustafa, for the invitation, and great to be with you, albeit virtually. And if I'm looking wrapped up, it's because my boiler's broken and I had to put on the warmest sweater that I could find. So my name's Ami Banerjee. As Sabine said, I'm a Professor of Clinical Data Science at UCL. I'm also a consultant cardiologist at Barts and UCLH hospitals. And I've decided to talk a little bit about digital health interventions in ethnic minority populations and before and after the pandemic. So I have a variety of roles rather than conflicts of interest, really, but just to make you aware, I'm a trustee of an organisation called South Asian Health Foundation, which is interested in ethnic inequalities in health and healthcare. I'm a trustee of Long COVID SOS, which is a patient-led charity for long COVID. And I have roles at the World Heart Federation, British Cardiac Society, and British Society of Heart Failure. The research that I'm going to tell you about is largely funded by NIHR, but I've also received grants for research from these funders listed here, including AstraZeneca and the EU before we made the decision to leave the EU. And I work 30% of the time clinically. So I'm going to very briefly give an intro about the context of big data and digital health interventions, a bit about the before and after the pandemic, where ethnicity and ethnic inequalities come in, and then our study. So this is all old hat to you, I'm sure, but the 5 V's are often used to describe big data: velocity, volume, veracity, variety, and value. And that's often used as a kind of why we're talking more about digital in the last decade or two than before. There's just more scope with the data type and the data volume that's there. But also it's this push towards trying to personalize what we're doing for health and healthcare. And so there's these 5 Ps that people have quoted: personalized, predictive, preventive, and importantly, both participatory and not just physical, taking account of the psychocognitive. And people like drawing circles and adding their own versions of these. So 5 V's has become 7 V's, and you can see that variability and visualization are also there. In that context, digital health is this umbrella term to capture lots of different aspects, but broadly speaking, there's mobile health, mHealth, there's IT, there's wearables, there's telehealth and telemedicine. But I've simplified it for the purposes of this talk into data, technology, and telehealth. So data, I don't need to explain what that is. Technology is really advances in process and product. And telehealth means using these technologies and data to deliver care remotely. So there's just a couple of slides about digital health interventions. They're different from drugs or other medical devices. They don't fit neatly into either of those boxes, and so how they're evaluated, how they're regulated is still a moot point. But there is some guidance at different levels. So the WHO, if you haven't seen, has published this actually quite accessible document about digital health interventions, and even if you just look at the figures or look at the executive summary, I found it quite useful. So it talks about the digital health interventions as complementary to looking at health content and the application of those technologies, and it talks through what the governance of these should be, how they should be regulated. There's European guidance by FPA in this space as well, that talks about the different stakeholders who need to be involved to develop the evidence base and to evaluate these technologies so that they're trusted in the right way by patients, by regulators, by health professionals. And my own kind of clinical community, the European Society of Cardiology, has guidelines as well. But one of the problems is that it's being done in different silos. So, the gastroenterologists are talking about digital health, the GPs are talking about digital health, cardiologists here are talking about digital health, but we need to have an overarching framework for this. And there's no end of like white papers and guidelines that are being published. Okay, so that's by way of background. Why is the pandemic of any consequence in the digital health space? Well, people have invented this term techceleration, that there's been different ways of working because of lockdowns, because of remote working, because of having to do your shopping or book your vaccination or pick up your e-prescription. All of those things have led to different behaviours, different ways of accessing healthcare and other areas of your life, including, as I say, online shopping. Lots more people are doing that than ever before. So these are already, as the pandemic is far from gone, but it's in a plateau phase at the moment, and people are thinking, what are the digital behaviors and technologies that are going to outlast the pandemic? So techceleration is this term to describe that. So I'm going to talk a bit about data, about technology, and about telehealth. First of all, looking at the divides and then the opportunities. So this is probably quite well known to you, and hasn't changed all that much, even though this is 7 years old. But when we get excited about genomics and omics, we should curb our enthusiasm, because most of the blood samples that are done in people of European ancestry who represent 20% of the world's population, and the 80% that's non-European ancestry typically is people like me who are British Indian, rather than people who are living in their native country of origin, if you will. So there's a huge mismatch. It's getting better, but I can tell you that whether you look at UK, US, Australia, or wherever there's a lot of funding of omic research, there's a big gap, a divide in terms of white versus non-white blood samples. So that restricts what we can say, and it's not just about genomics, of course. If we're making assumptions about how the environment interacts with the genome, epigenetics, then you need to have that data from a wide range of people, a representative group, in order to make those assumptions as well. So this is a data divide that we have. In the pandemic context, this is just a very quick slide to say that we were able to access large sets of data, and still are doing, in a pandemic emergency context that we haven't otherwise been able to do. And it's very interesting, really, that we've debated whether we should be able to access population data, but we were able to pre-lockdown access records of a large proportion of the population to do modelling of how many people in high-risk groups would die if we allowed infection rates to reach certain levels over the next year. And we did that in a matter of 2-3 days. So if the right data is there with trusted research environments, but open to the research community, then good can come of it. And that's these analyses were done when really very few people had died from COVID. And you can do quite simple, pragmatic calculations. And interestingly, though, we couldn't access ethnicity data in this sample, or rather, because the linkage for ethnicity was not there for primary to hospital data in this timescale. We had 70% of the data missing, so we couldn't do good analysis on ethnicity. So there is inequality in that data. We importantly were able to interact with patients and public, including people from young and older age groups, including people from different ethnic minorities via HDR UK. And again, this is something that typically we did less of before the pandemic in terms of online focus groups, online engagement, and it's something that, in order to reach out more, we might do more of. And the trusted research environment we've been using for the most part is via the British Heart Foundation, Data Science Centre, and what was NHS Digital and what was Public Health England. Obviously, they've both changed names now. But the idea is that you have the UK's strength in its primary care data, that everybody's registered with a GP, and then you can link to other parts of their health journey from cradle to grave, whether that's in terms of disease-specific registries, whether that's in terms of COVID-specific data, whether that's hospital episode statistics or intensive care data. And that's de-identified, linked. And we have over 300 researchers across, I think at the last count, it was over 40 institutions represented, from hospitals to universities, working collaboratively with this data. And there's literally tens of outputs that have come out. So I think that we're in this interesting space where data until now had been very much governed by the privacy agenda, but health data for public good might be a different angle. But at the moment, we can only use it for COVID. And as COVID deaths reduce and the impact of other diseases reaches pre-pandemic levels or beyond, then how can we ethically justify not looking at the data for those? And when we published this protocol paper, one of the lead for the patient panel in HDR UK, Lynn Laidlaw, actually wrote this comment piece that basically anything that we do has to involve patients. How we decide, who gets to decide what research question the data will be used to answer. Let's ensure that people's lived experience of cardiovascular disease in this case is respected to make us more than a data point. That's relevant because still in PPI and patient and public involvement, ethnic minorities are underrepresented. So that was data. This is technology. this is some work we did funded by NIHR before the pandemic to show that even if you look at the traditional social deprivation indices, homeless people have much higher rates, regardless of gender, regardless of which territory you're looking at, whether it's heart, cerebrovascular or peripheral vascular. You're looking at higher incidence and higher prevalence of disease. And this is a technology divide, because even though they have higher rates, they have less access to even simple, on at the higher end, we're talking about the latest pacemakers and the best possible stent. And in this population, we're not even getting glucose screening, blood pressure screening, ankle blood pressure index screening. So we need to make sure that we level up, and prevention in this population, from primordial through to tertiary. So primordial is where you're trying to prevent the risk factors from happening in the first place. Tertiary is where you have established disease, and we need targeted strategies in these kind of harder to reach groups. So in inverted commas, and in homelessness, obviously there is an overlap. You might think, why am I mentioning homelessness? And I talk about ethnic inequalities. It's because inequalities are intersectoral. Perhaps in this age where we're talking about multiple long-term conditions or multimorbidity, we're talking about the latest NIHR jargon is compound pressures. So multiple pressures on health systems. In that context, to look at one inequality at a time doesn't seem fit for purpose. We should be looking at the intersection. Now, during the pandemic, we did so much online or via phone, whether it was booking of appointments for your vaccine, whether it was, as I said, picking up prescriptions and so on. And we had a digital-only policy in England, really, and we had a digital-first policy north of the border in Scotland, which was very interesting, meaning that you could opt for non-digital options. And so we wrote this comment piece, just looking at that in the Lancet Public Health, that actually that did affect inequalities by ethnicity and by socioeconomic status, and digital first would be the preference. And so you have, in the case of the pandemic, you had, from early stages, I'll come to this in a minute, clear ethnic inequalities in mortality, and you have the people who are most at risk, i.e. older ethnic minority adults, being least likely to be able to use the digital technologies, and so that's where the barriers are. And so the technology was less adopted, and so you can get to a position where the solution, which was vaccination, is harder to reach if you're only going to do it digitally. So you have a digital exclusion. Outside of COVID, one of the things that is spoken of a lot is artificial intelligence and machine learning. So that is where you have computer algorithms that are performing specific functions and learning while they're doing so, and sometimes outperforming us humans, and sometimes replacing our function so that we can be freed up to do other things. Now, in the cardiovascular space, there's two things in particular that AI is used for. So one is defining subtypes of disease, such as heart failure or such as heart attacks. and the other is predicting risk. Now, we did a systematic review of about 100 or so articles about these two types of study, just in the cardiovascular space. And if you look at the three colors in these bars here, there's blue, red, and green. So there are 3 steps in development of AI technology for use. One is, the blue is the development phase, red is when it's validated, where you prove that it works outside of your kind of original data set, and the green is where you decide whether it's effective or cost effective. And I won't go into all these individual bars, but none of them are anywhere near 100%, meaning that in all of these studies, they were deficient at these different stages. Notably, there were very few, less than 15%, which had low patient selection bias, and there were few that had good patient applicability. That's relevant to ethnicity, because a lot of the data sets used were either ethnicity not available or in populations where they weren't diverse. Also, there's very few studies, 12 and 5% respectively, where you had validation. So people use just one data set and it might not be validated externally, might not be usable externally. And then these zeros mean that there have been no studies of effectiveness and cost effectiveness. So when we talk about AI and is it ready for use, in this particular example of cardiovascular disease, it's not based on our current literature, and definitely not in harder to reach populations. Telehealth, finally. So telehealth is such as remote consultation and so on. We saw a lot more of this during the pandemic. This is an example of remote consultations with video by the GP. That was a private example by a company called Babylon. Obviously, people have to be able to pay, and that's a layer of inequality there. And this study looked at all of the digital health applications that had been published during COVID, which was many. And interestingly, the vast majority were in the green, were telehealth. But there was also a lot of AI there. This is Internet of Things, for example. But so just to say that in the digital health technology space, telehealth is dominant. And there's a huge opportunity because so many people use wearables, whether that's Fitbits or Apple Watches. But again, people are paying for these out of pocket. So, it's not accessible to everybody. And this is one of the largest clinical trials ever, and definitely in the cardiovascular space. This is the Apple Watch study, published in the New England Journal of Medicine. And they recruited nearly 500,000 people in a 9-month period in the US. And they're using this technology because the Apple Watch latest generation has the ability to look at a single lead ECG and diagnose atrial fibrillation. So the idea was, can this effectively diagnose atrial fibrillation in the population? And it's a huge opportunity. You can see, if you can recruit to a trial that quickly, it's incredible. But this is just to show you that there are problems even in the New England Journal of Medicine, and even in this scale of study where they recruited, over 400,000 people, and they do this nice flow diagram, the Prisma diagram. And what they do is when you do this, you should always report with this denominator. But what they do is they cheekily go down the flow diagram and report 43.7 and so on, all the way down. For example, at the end here, they in the abstract and in this diagram, they say that 56% of people complete an end of study, but you can see that out of 400,000, 450, and out of that 250 finish. So this is to the point that digital health and telehealth, often people say you can't do trials or you can't do studies in this, it's too rapidly moving. I don't think we should lower the bar of science to push through digital health technology. We can't, on the basis of this study, for example, recommend our patients have Apple Watches to diagnose atrial fibrillation. There's a huge digital opportunity to educate me and my colleagues, health professionals, who, if you want to roll out digital health technology and you want to reach across inequalities, then you need to be able to make sure that health professionals know about it. We know that in undergraduate education, there's a poor teaching of informatics and digital health. So 5 years ago, we set up the first module that's compulsory in the country. So across the 5 years of medical school, there's a module called Doctor as Data Scientist, where not only are people learning about digital health, but they're learning to have a critical eye to spot the wheat from the chaff. And the direction of travel is that we need competencies, the same way as I need competencies to examine and take a history based on certain organ systems. I need to be competent in health informatics and digital health as well. Okay, ethnicity. So early on in the pandemic, it was noted, and if you go back, this tweet by my friend and colleague Kamlesh Kunti from University of Leicester, I think it was the first, at least in the UK, realization that there's a difference in mortality. This was in the ICNARC data, so people in ITU who were being admitted with COVID, there's a difference by ethnicity. And then they wrote an editorial in the BMJ. So we knew early on in April. And again, in some ways, this is a good news story during COVID of how we were able to spot the problem, document it, validate it, and try and find solutions. If you compare it to my home ground of cardiology, we've been writing about and researching about and providing care about cardiovascular inequalities, and whether it's the data or the actions arising from the data, it's taken longer. So this, I think, in some ways, although it was very worrying at the time, it was a good news story. And I reflect that this is an example of a learning health system. So for those of you who might not be aware of this terminology, this is where you connect these three silos: science, which is research; evidence, which is guidelines and guidance which governs practice; and care, which is what we do to patients or for patients. And if you link those together, i.e., that data from ICNARC about critical care shows us which questions we should be answering in the science, rather than the other way around. And the Office for National Statistics has been, in my view, nothing short of heroic in terms of data science during the pandemic. Every week you're getting updates, sometimes with Excel spreadsheets that anybody can download and interrogate, and you can contact them. And they've been publishing not just ethnicity, but breakdown by age and sex as well, for COVID mortality, and also for long COVID. But this evidence was also showing the inequalities. So you had the research, and you had the evidence or guidance coming from our national bodies that's showing the same. And our charity, South Asian Health Foundation, was one of several to produce reports and recommendations in this space, which were trying to be culturally competent across different ethnicities. And we, this is just to show that it's in the last 3 years, there's been a mushrooming of how much data and evidence that you have to sift through, whether it's in journals or whether it's in preprint. But you still have to look at the quality of that data. But all of them, showed this ethnic inequality, this compared with white populations, a higher mortality risk. And we were able to see that, as I've said, across gender, across age. Let's skip through these. And by comorbidities, by social deprivation. And importantly, in different analyses, we've been able to, so this data is about risk of diabetes following COVID, but we've been able in epidemiological terms and data science terms to try and see how much of the impact of ethnic inequality might be explained by other factors, such as age, gender, such as deprivation, such as overcrowding in housing, such as comorbidities, which is really important. And we don't always have that data available. This is for type 1 and type 2 diabetes. And I mentioned that South Asian Health Foundation report. We produced this framework for a mixed audience, really, to try to look at that intersectorality that I mentioned. Ethnicity is just one of the things here. So when people talk about ethnic inequalities, you have to think about occupation, gender, et cetera, all the way to environmental characteristics. Now, getting back to digital tangentially, so you've got from an early stage, as soon as the vaccines were rolled out, you could see that in blue, this was the Black population was having much lower rates of vaccination than the white population and other ethnic minorities. And when you look at the first, the second and third waves, this on the right here, colleagues at the ONS have compared with the white population different ethnicities and vaccine uptake, and what you see is that all of them have a lower rate than 1. If they were the same as the white population, then it would be 1. And some populations, again, the Black population, whether it's Black African or Black Caribbean, has had lower vaccination rates throughout the pandemic. And we've even been able to look at that by doses of vaccination. I'm showing you this because in my home ground of cardiology, to see this granularity of data is unusual. You don't see blood pressure medication, statin use, and so on so easily in national data at different times in near real time. And you can look by ethnicity. You can look at, so purple here is how many people have had 3 doses of vaccine, 2 doses, and so on. And across all of these waves 2 and wave 3, that ethnic inequality has persisted for the Black population, but it's got better for the other ethnic minorities. This is an analysis in the British Medical Journal where Kamlesh Kunti and the ONS looked at the hazard ratios or the risk of COVID-related mortality by ethnicity and they adjusted the model for different factors across the top here, housing, socio-demographic characteristics. But the important one is vaccination explained most of, or at least some of the impact of ethnicity. So differences in vaccination by ethnicity seem to have some impact on the mortality. But a good news story is that for most ethnicities and by gender, vaccination had really reduced that risk, except for Bangladeshi males for some reason, and Bangladeshi females, where the rates of vaccination were lower. This is post-COVID and chronic disease. We've seen less data about ethnicity in this space, but where we have seen it, interestingly, although there was a higher rate of COVID mortality acutely, there's seemingly less long COVID in different ethnic groups. Now, from common sense, that's unlikely. It's more likely that these groups are not presenting to health services with long COVID as much. In terms of what we did, this is, I think, a good news story, whether it's at individual level, at workforce level, workplace level. And a lot of this was, why am I talking about this in a digital health talk? A lot of this was done digitally during lockdowns, risk assessment and so on. Ethnicity was very much part of that. And we and others have developed targeted messaging for different communities. And there's a lot of, and still is a lot of activity online, whether on social media or YouTube, for increasing vaccination rates, reducing those disparities that I said. So there are, beyond the pandemic, there are things that I think, whether it's data, whether it's digital health technology, that we can take forward. And I've mentioned the digital first aspect, but we'd started this project called DISC before the pandemic, only 6 months before, and we had been given the task really by NIHR to look at cardiometabolic disease, so cardiovascular disease and diabetes. We'd originally wanted to look across ethnic minorities, but they'd said do a deep dive in one large ethnic minority group. So we did that in South Asians, and to look at digital health technology. So we've called that study DISC, which is Digital Interventions for South Asians with Cardiometabolic Disease. And there are already, before the pandemic, there's lots of things that are digital in this space, whether it's promoting cardiovascular health, as in diet and exercise, whether it's testing and monitoring to diagnose and treat disease, to diagnose and monitor disease, or whether it's telehealth or reminders for care. Sorry that the title has moved down here, but our research questions in this project, which, as I say, started before the pandemic but ended up happening during the pandemic, were what do we know about use of digital health interventions by South Asians, and what are the barriers to uptake, use and effectiveness at individual through to population level. And you can quite easily imagine what those different barriers are, from individual on the left through to population on the right. you have your personal beliefs, your community support, you have the specific digital health intervention itself, you have system level factors, and then you have population or national level factors. And then across the bottom is the so-called social determinants of health. So we have, we'd structured this work across 3 work packages. Firstly, to look at 3 reviews. Firstly, a realist review of what works in terms of digital health interventions for cardiometabolic disease. And that's been published in the Journal of Medical Internet Research. We did a policy content analysis, which has just been accepted by the Journal of Health Policy, where we looked at the last decade of policy documents from disease-specific organisations and the government, which mentioned digital health, and saw what happened. And that shows that although digital health has been something that's commonly mentioned, there's not much meat on the bone of how to implement or how to reduce inequalities in the space. And we also did a scoping review of frameworks, because we know from what I've already told you that digital health technologies are evaluated in different ways. So what frameworks should we use, and is there a way of combining frameworks rather than, every single successive researcher publishes their own framework? So these are pieces of work that we've completed. We've done focus group discussions before and after the pandemic with patients, non-patients, mostly carers, health professionals, but also with the people in the industry as well who are developing technology, to understand what their perception of the barriers and facilitators are to digital health technology. And then with specific digital health technologies, for example, the Freestyle Libre, which is continuous glucose monitoring. We've interviewed individual patients to see how they use that technology and what they see at an individual level the barriers are, and to look at the higher level or population level barriers. We've also got two types of work that we've done. One is a survey online during the pandemic of patients, public and health professionals, and also key informant interviews and focus group discussions.
Ami?
Yeah.
Just to make you aware of time, so we're 12 minutes away from the end.
Thank you. I'm just about done. Thank you.
All right.
I do tend to go on. I do apologise.
That's all right. That's all right.
Yeah, this is we're due to finish in July, and the qualitative work will be in preprint, I hope, in the next month or so. It's a large team of people across organisations and universities, and lots of patient representation. So there's still room for discussion about how we evaluate digital health technologies. I've split it into data, technology, and telehealth, but you can cut it in different ways. But digital health is a useful term because it's kind of catch-all. So I think we do need to do that to some extent. I think these advances that we've seen during the pandemic, we do need to learn from them and take the good bits across to other disease spaces. Evaluation is key. Health professionals, including doctors, need to be able to understand digital health technology and the shortfalls of it. And I think in this work in DISC, we've learned that ethnicity is one dimension of inequalities, and we've looked at it in one disease area in one ethnic minority population. That's one way of doing it, but I think there's applicable things that could be in other ethnic minorities and in other diseases. And so we should kind of study that at bigger picture level. I'll stop there and happy to take questions. Thanks.
Thanks, Ami.